So dialectical behavioural therapy was developed by a lady called Marcia Linehan in the late 1980s. It's a type of cognitive behavioural therapy that was developed to treat chronic suicidal individuals diagnosed with borderline personality disorder. So DBT goes that step further than the standard cognitive behavioural therapy in emphasising and teaching patients to accept themselves and their world as it is in the moment. So DBT is the gold standard treatment for clients with borderline personality disorder. It was originally created for BPD, however, it's now being used in a wide range of settings and has also been found to be effective with service users with PTSD, with depression, and with anxiety disorders. It uses both skills training and individual therapy. So the complexity of the client group. So research has found that amongst service users with borderline personality disorder, 66% that completed suicide have had BPD, 75% have attempted suicide, multiple hospital admissions, multiple treatment providers, and as Marcia Linehan would say, the most difficult patients to treat. As you can see here, the skills training alone has been found to be effective in many settings, but also for many disorders. So now we're seeing DBT being implemented for people who have binge eating disorders, childhood trauma, depression, ADHD, bipolar. And you can have a look at these at the end yourself. So this is the gold standard research that's been completed. Okay, so moving on, if we look here, we have the three states of mind. We have a rational mind, an emotion mind, and a wise mind. My job as a DBT therapist is to get patients into that wise mind. Patients that meet the criteria for borderline personality disorder tend to stay in that emotion mind. In that emotion mind, it's extremely difficult for patients. They're reactive, they're impulsive, they self-harm, they find it difficult. And this is where you see patients perhaps turn up at A&E having cut themselves. Okay? So my job is to teach them skills to get into that wise mind, so balancing that rational mind with that emotion mind and bringing it together. Marcia Linehan believes that patients that are diagnosed with borderline personality disorder have deficits in skills and therefore are unable to get into that wise mind. The modules that I teach patients are interpersonal effectiveness, emotion regulation, core mindfulness, and de-stress tolerance. I've only listed some of the skills here. So we have self-soothe, radical acceptance, turning the mind, the pros and the cons, improving the moment, the three states of mind, the model for describing emotions, problem solving, opposite action, checking the facts, and wise mind. These are just some of the skills we're doing at the moment. So the rationale for the skills group within the Belfast Trust is that psychological interventions are for all service users. The skills we teach patients increase emotion regulation, and we won't see them turning up as much at A&E. So there's going to be a reduction in self-injurious behaviours, those kind of risk-taking behaviours, and hospital admissions. Also, the skills are appropriate for a range of diagnoses, including the complex and comorbid presentations. They're timely and cost-effective, and they're in line with NICE guidelines and the gold standard treatment. They're accessible for all service users and those with complex needs. Service users can access these skills within their own community. And it's a way of empowering our service users with the skills and the knowledge to tolerate and manage a crisis without resorting to those more impulsive behaviours, the self-harming behaviours, the suicidality. So moving on, I'm going to introduce my colleague who has helped me set up these DBT skills groups within the Belfast Trust. And her name is Kirsten Jordan. She has also helped me evaluate these services, and we've had some really, really good feedback. So I'm just going to introduce Jordan, or Kirsten.
Thank you, Kathleen. So as discussed, there was a really strong rationale for establishing DBT skills groups within community mental health teams within the Belfast Trust area. Kathleen took leadership on this as a senior nurse practitioner with the assistance of myself and another associate psychologist, bringing a really lovely multidisciplinary approach to care, sharing knowledge and skills and kind of strengthening our approach through that. So as this initiative began as a pilot, we were really keen to gather detailed data on the establishment and delivery of groups in order that we might adapt and shape the groups and the service based on that data captured. So as you can see in the graph here, based on data from the beginning of February 2019 to the beginning of February 2020, a total of 707 referrals have been received for group work. 412 of these were for DBT skills groups, distress tolerance and emotion regulation. The majority of referrals were from primary and recovery teams. We continually shape the groups that we offer according to the presenting needs. For example, we noticed that there had been an increase over time in referrals for emotion regulation groups and psychoeducation groups, anxiety management. And for that reason, we decided to increase the number of those groups offered. Moving on to service user feedback. Groups are continually evaluated in order to ensure that what we are offering is accessible, acceptable, and effective. We do this by asking service users to complete an outcome pack at 2 time points, baseline and post-group. All packs contain qualitative, for example, demographics questionnaires and patient experience of care questionnaires, and quantitative outcome measures, some of which are presented today. The data here is based on average ratings from over 100 service users, and as you can see, when asked to rate different elements of the groups, including the content of the sessions, the relevance of the sessions, expectations, and satisfaction, mean scores are high. The lowest score was the number of sessions, with some service users commenting that there simply weren't enough, and they would have maybe appreciated the groups to continue for longer. So along with rating certain elements of the groups, service users are provided an opportunity to comment. This gives us really rich information that provides a deeper insight into the experiences of those who've attended the groups. For example, one service user commented that they had an awareness of many of the skills before attending the groups, but attending gave them more confidence in the application of those skills. Many service users also commented on the power of shared experience within the group, which would be reflective of the general research suggesting the effectiveness of therapeutic groups. At times, it can feel like the validation and acceptance service users receive from other service users can be an intervention in and of itself. Some of these suggestions and feedback comments are really practical and easy to change, but can make a huge difference, ensuring that those attending feel as welcome and as comfortable as possible. Something as simple as how we label the group or the style of the handouts provided can make a really big difference. And it's been mentioned in various different presentations today, service user experience is really paramount, and we really try to make sure that's part of our service delivery. Thinking systemically, it was important for us that service users benefited from the groups, but also that referring agents and key workers were satisfied with the service. Once a year, referring agents are invited to complete a feedback questionnaire. For this evaluation in particular, 39 referrers were invited to take part and 14 responded. Those who responded were all from primary and recovery teams, and the average number of service users referred was 11. As shown, the average ratings given are high. In particular, professionals indicated that they would be highly likely to recommend the groups to other professionals and to other clients, indicating a degree of trust in the service. And again, shown are some of the comments given by referring agents, with that qualitative data giving us a really rich picture of the referrer's experience of referring service users to the group. Themes include prompt access to input, peer support received, and increased use of coping skills in the place of unhelpful destructive behaviours. Another theme highlighted was communication. Referrers requested that they be kept more informed of the groups and service users attending, and this has been really helpful feedback for us, prompting us to increase our lines of communication, taking a more incorporated approach by involving referrers. This has led on to kind of informal staff training opportunities and consultation. This brings us to the end of our presentation on this initiative. Thank you so much for taking the time to listen and for inviting us here today. And we'd love to chat with you afterwards. I'm going to hand over to Kathleen to answer any questions anyone might have.